Hey everyone, welcome back. You guys sent in a ton of interesting stuff about blood pressure,
Oh, yeah.
especially all about how it's monitored in hospitals and stuff. We're calling this deep dive arterial pressure monitoring,
Okay.
and we'll be looking mostly at excerpts from arterial pressure monitoring PP.
Sounds good.
It gets pretty technical, so get ready.
Yeah, I'm excited to break it all down. We're not just talking about, like, what blood pressure is.
Right.
We're going to really see how doctors actually monitor it in a clinical setting.
Exactly. So let's start with, blood pressure 101.
Okay.
The source defines it as the force of blood pushing against artery walls.
Uh-huh.
Simple enough.
Yeah. I mean, the interesting thing is it's not a static thing. It's
yeah.
a dynamic process. It's really the interplay between the heart pumping the blood out
Okay.
and then the resistance it encounters in the arteries.
That makes sense.
Yeah.
And we all know about systolic and diastolic,
Right.
the two numbers that we
Yeah.
get at the doctor's office.
Those are the two big players in the blood pressure story. You can kind of think about it like waves crashing on the shore.
Okay.
Systolic is like that peak force when the wave hits, and diastolic is the calmer pressure
There you go.
between waves.
Ooh, I like that. So what should we consider normal for these numbers?
Yeah, so the source gives us a range of like 90 to 140 millimilli Hg for systolic,
Okay.
and then 60 to 90 for diastolic.
Got it.
But, just like no two waves are exactly the same.
Right.
Normal can vary a lot from person to person.
Yeah, that's where knowing your own baseline blood pressure is really important.
Absolutely.
Like before you get sick or whatever, what's normal for one person
Right.
could be a huge red flag for someone else.
Totally. And there's another thing that can affect it. Gravity.
Wait, gravity. You mean like if I'm doing a handstand in yoga, it'll be different?
Haha. Not quite that extreme,
Okay.
but you're on the right track.
Okay.
When you stand up, your blood has to work a bit harder against gravity to get up to your brain. Interesting. So that's why the readings can be a bit higher standing up compared to lying down.
Oh.
Doctors will usually measure at heart level to be the most accurate.
Okay, so position matters. I'm starting to see there are a lot of variables here.
Yeah, and we're just getting started. We got to add another layer now. I mean, arterial pressure or MAP?
MAP, that sounds important.
It is. MAP is like the average pressure in your arteries
Okay.
over a whole heartbeat cycle.
Got it.
Doctors really like it because it gives a much better overall picture than just looking at systolic and diastolic separately.
So how do they even calculate this MAP number?
It's a pretty simple formula. Diastolic pressure times 2 plus systolic,
Okay.
and then all that divided by 3.
That.
The normal range is 70 to 100 millimillis GFN.
Okay. But why is this MAP number so important?
Right.
The source makes it sound like it's like the VIP of blood pressure readings.
It's all about consistency and prediction. You see, MAP is pretty stable across your whole arterial system, so it gives a really reliable measure of overall blood flow.
So it tells you how well your organs are being supplied
Yeah.
with oxygen and nutrients and stuff.
Exactly.
Wow. So MAP is like the doctor's secret weapon for
Ah.
understanding what's happening inside us.
It really is. It gives them that more holistic view than just those snapshots of systolic and diastolic.
I'm impressed with MAP now.
Yeah.
Okay. So how do we actually measure all this pressure?
Right.
I know the basics, like the inflatable cuff
Yeah.
at the doctor's office and like those wrist monitors you can get.
Those are good for like a quick check.
Yeah.
But they have limitations,
Okay.
The traditional method, using a stethoscope and listening to the sounds as the cuff deflates, that's called auscultation. That's like the gold standard, but it takes practice.
Right.
And then there's palpation, where they just feel the pulse to get a rough estimate, but those manual methods can't always detect diastolic pressure very well. And then you have automatic devices, which are convenient,
Yeah.
but they can be iffy, like if you're moving around a lot.
So what happens if we need constant monitoring, like during surgery or in intensive care?
That's where we use arterial lines.
Ooh, arterial lines. I've seen them on TV,
Yeah.
but I never really knew what they were.
You can think of it like a direct line into an artery,
Oh, wow.
usually in the wrist,
Okay.
connected to a monitor that shows the pressure changes.
Okay.
It's a really thin tube, so it's not as scary as it sounds.
So why would someone need like direct access to their artery?
There are a couple reasons.
Okay.
Like if someone needs their blood pressure monitored constantly.
Like during surgery.
Yeah, exactly. Or if doctors need frequent blood gas measurements, that tells them about the oxygen and CO2 levels in the blood.
I can see why that would be so important in critical care.
Mm-hmm.
But I bet there are some risks with having that tube directly in your artery.
You're right. While it's really useful, arterial lines are not without potential complications. We should definitely talk about those.
Let's do it. I'm ready.
Yeah, before we get into the risks.
Okay.
It's really important to remember that informed consent is key.
Right, of course. So you're talking about patients understanding the potential benefits and risks before agreeing to it.
Exactly. Unless it's like a crazy emergency, patients need to be in the know.
Right.
One of the big risks is something called arterial embolization.
Embolization. That sounds kind of scary.
Yeah.
What is that?
It's basically when an air bubble or a blood clot gets lodged in the artery, and that can block blood flow to the tissues downstream.
So like a traffic jam in your artery?
Perfect analogy. Okay. And the source mentions a particularly bad type, cerebral embolization.
Oh, no.
That's where the blockage goes to the brain.
Oh, wow.
That's when things can get really serious, could even lead to a stroke.
Yeah, that highlights how important it is to do this carefully.
Oh, absolutely. Proper technique is crucial, especially when flushing the line, to minimize that risk. And it's not just embolization we have to worry about.
Right.
There's also the risk of damaging the artery itself, especially if it's a smaller one.
So using a bigger artery is safer.
Generally, yeah. That's why the source mentions different sites for placing the line.
Right.
Like the radial artery in the wrist, the brachial in the arm, the femoral in the groin.
Okay, so the choice depends on the person and the situation.
You got it. And the risks at each site.
Okay.
Like the radial artery is popular because it's easy to access and has good collateral circulation.
Collateral circulation, what's that?
It basically means there are backup routes for blood to get to the hand.
Okay.
Even if the radial artery is blocked.
Wow, that's pretty neat.
It is. But if the patient has circulation problems in their hands already, then a different site might be better.
So it's like choosing the best route.
Yeah.
Based on the individual's own roadmap.
Exactly. And in emergencies, the femoral artery is often used because it's bigger and allows for quick access.
Makes sense.
And you can do rapid fluid resuscitation if needed.
Okay, so each site has its own pros and cons.
For sure. Yeah. And as the source emphasizes, each site comes with its own hazards.
Yeah.
We talk about embolization, but there's also infection, bleeding, and even accidentally injecting meds meant for a vein.
Okay, that is a lot to think about.
Yeah.
It seems like deciding to use an arterial line is a pretty big deal.
It is, and that's why informed consent is so important.
Right.
Patients really need to know all the potential downsides before making a decision.
But the upsides, too.
Oh, for sure.
Like how precise the monitoring is.
Right. Arterial lines provide amazing info, allowing for super precise adjustments to meds or fluids.
It's all about weighing those benefits against the risks.
Yeah.
Like a high-stakes balancing act.
Exactly. Speaking of balance, remember that crazy fact we talked about earlier about the pressure wave being faster than the blood flow?
Oh, yeah. Like a secret super-fast communication system.
Oh, no, right? Amazing. And that speed also affects how aging changes blood pressure readings.
Okay, how so? How does aging affect the pressure wave?
Well, as we age, our arteries naturally stiffen up. Kind of like a garden hose losing flexibility.
Okay.
This stiffness makes the systolic peak of the pressure wave higher.
So it gets sharper as we get older.
You got it.
Yeah.
And that's just one way aging affects the arterial pressure waveform.
Interesting.
Which is what doctors see on the monitor.
So it's like each heartbeat creates a little signature.
Yeah.
And that signature changes over our lifetime.
I like that. And it's not just age.
What else?
The source mentions things like arrhythmias.
Arrhythmias, those are irregular heartbeats, right?
Mm-hmm.
I bet those mess things up.
Totally. An arrhythmia makes the waveform look crazy.
Okay.
With irregular peaks and valleys.
Ah.
Then there's hypertension, which is high blood pressure.
Right, so that would make the whole waveform higher.
Exactly. And on the other hand, low blood pressure, hypotension, that would make the waveform lower and flatter.
So the waveform is like a window into the cardiovascular system.
It is.
It's like a secret code that doctors can read.
Exactly. Skilled clinicians use those subtle clues in the waveform to make important decisions about patient care.
It really shows the power of this technology.
It does. But, like we said, with great power comes great responsibility.
Right.
We have to use this tech wisely and ethically.
Of course.
Always putting the patient first.
Couldn't have said it better. And speaking of that, maybe we should go back to informed consent for a minute.
Yeah, good point.
The source says there are no absolute contraindications for arterial lines.
Right.
Wait, what does that mean? Anyone can get one.
Not exactly. It means there's no one condition that automatically excludes someone.
So someone with a bleeding disorder, for example, could still get an arterial line if the benefits outweigh the risks.
Exactly. It always comes down to a judgment call, carefully balancing the pros and cons.
So it's not a one-size-fits-all approach.
Nope, definitely not. Every patient is unique.
Right.
And the decision should be made on a case-by-case basis.
I'm realizing how nuanced these decisions are.
They really are.
It's not just about the technology. It's about understanding the patient's needs.
So sad. And that's where the healthcare team's expertise is so important.
Yeah.
They have the knowledge to weigh all those factors, explain everything to the patient clearly, and help guide them to the best possible choice.
It sounds complex.
Yeah.
But it's reassuring to know so much care goes into it.
It really does. It's all about combining the tech with compassionate care.
Okay, I think we've covered a lot.
Yeah, we have.
The science, the technology, the risks, the benefits, and the ethics.
We've seen how this tool can give us incredible insights
Yes.
into our cardiovascular system, but also how important it is to use it responsibly.
And I think the main takeaway is that it's not just about the numbers. It's about understanding the whole person.
Absolutely.
And making informed choices that put their well-being first.
Couldn't agree more.
Okay, deep divers, we're ready to wrap up this episode.
Okay.
But we don't want to leave you hanging.
Of course not.
We have one last thought-provoking question.
Okay.
So stay tuned for the last part of this deep dive. Okay, we're back. Ready for the final part of our deep dive into arterial pressure monitoring.
I'm ready.
We've gone over a lot.
We have.
From the basics all the way to how this technology is used in medicine.
Yeah, it's been quite a journey. We've looked at how the heart and vessels work, how to read those pressure waveforms, and even the ethics of using such powerful tools.
And now we've got one final thought-provoking question.
Okay, I like it.
To leave you guys with.
Shoot.
As you continue exploring this topic.
It's one thing to get the technical stuff, but the really cool part is seeing how it leads to better care for patients.
That's so true. It's not about numbers on a screen. It's about people's lives.
Exactly. So here's the question. Imagine you're a doctor.
Okay.
And you have a patient who might benefit from an arterial line.
Mm-hmm.
Knowing the benefits and risks, how would you decide what to do?
Ooh, that's a good one.
Especially in different situations.
Yeah, like, is it a no-brainer for major surgery?
Right.
But what about someone who's stable but needs to be watched closely overnight?
Exactly. And what about the patient's age?
Right.
Their overall health, their personal preferences?
This is where the science and the art of medicine come together.
Yeah. It's not just a checklist.
No.
It's about making smart choices for each person.
It's about putting the patient first.
This deep dive has really shown me how complex healthcare is.
Me too. It's always weighing benefits and risks, considering each patient's situation, and always trying to get the best outcome for them. And sometimes the best outcome might not even be the most high-tech thing.
You're right. It's about picking the right tool for the job, whether it's an arterial line, a different monitor, or something else entirely.
Well said. We hope this deep dive into arterial pressure monitoring has given you some good insights.
I hope so.
And maybe made you curious about how medical decisions are made.
And remember, deep divers, knowledge is power.
Yes.
And more you know about your health, the better you can work with your doctor.
Absolutely. So keep those brains working, everyone.
Keep learning.
And if you find something interesting you want us to look at,
send it our way.
Send it in. We love a good challenge.
We do.
Until next time, stay curious.